Okay, good morning, everybody. My task today is to talk to you about gout management. Now, gout is an important topic for general practitioners for several reasons. Firstly, as Dr. Aqil mentioned, that gout is the most common form of inflammatory arthritis. Therefore, you are likely to see more gout patients than patients with rheumatoid or psoriatic arthritis. Prevalence of rheumatoid arthritis is 0.8%, while the prevalence of gout is 2.5 to 4% depending on the country. Second reason why gout is an important topic in general practice is gout is serious disease with devastating long-term consequences. So if you don't treat gout, by treatment I mean urate lowering therapy, because that's the treatment. So if you don't treat gout on the long term, there will be joint damage, there will be increased cardiovascular morbidity and renal disease. Thirdly, gout is severe. It is the most painful arthritis. It has significant impact on the patient's quality of life. So patients regard gout experience as a life-changing event leading to misery, job loss, and disability. Lastly, gout is curable, which is good news, compared to other forms of inflammatory arthritis that are chronic, and we can only control them with medication, but we cannot cure them. But gout can be cured. So it's a shame not to treat a curable disease. Right. So this was supposed to be an interactive form of question for you, but I don't know, it's not working. I was just asking you, how confident are you in treating gout? So anyone is like confident in treating gout in this room? Dr. Aqil, of course. And who is not confident? Can you see are you getting because somebody is voting, okay. Who's not confident in treating gout? Yeah, I'm just reading لأنه ما قاعد يطلع. So the answer is confident, not confident, or so. So I just wanted to know before I start how confident the audience are not confident in treating gout. Right. So before I start with the talk, I just want to mention the common mistakes in gout management that we notice in general practice. So when you look at how gout is managed in general practice, a common theme of management mistakes is readily observed. The most common mistakes are which drug to treat acute attacks. So they're not sure which drug to choose. Should we give steroid, non-steroidal, colchicine? The second thing is not starting urate-lowering therapy. And if urate-lowering therapy is started, not achieving the target serum uric acid level. So when we start urate-lowering therapy, we aim at a certain uric acid level, and if we don't reach that aim, we have to increase the dose. So the practice in general medicine is that they give one dose and that's it, and they don't check if the patient reached the target or not. The other thing is not educating the patient on many aspects of gout, and that leads to treatment failure because, believe it or not, patient education is the most important element in gout management. If you don't educate the patient, he will not adhere to the treatment and your treatment will fail. And the other thing is stopping urate-lowering therapy during acute attacks. So these are the mistakes we notice in gout management. Now, when we talk about gout management is not only treating acute attack. For gout, of course you need to treat acute attack because obviously they're very painful, but you need to cure the gout with initiating urate-lowering therapy. You need to educate the patient so that they adhere to treatment and your treatment will be successful. And as Dr. Huda mentioned, comorbidities and rheumatic diseases, you need to screen all gout patients for associated comorbidities that are very common with gout. They're even more common than rheumatoid and lupus, which are the hypertension, diabetes, hyperlipidemia, and renal disease. right? So how to treat acute attack? So the first thing is treating acute attack. So to understand how to treat acute gouty attacks, one must know what is the process that we are trying to stop by giving acute attack medication, like for example, colchicine or nonsteroidal. So why are we giving these medications for acute attack? Now, as we all know, gout patients, they go through alternating periods of having acute gouty attacks and being asymptomatic. So periods of being asymptomatic and then periods of acute gouty attack, and they alternate between these two stages. So if crystals, and as you see, sorry. So these yellow little things in the joint are the crystals. Sorry, is this not working? Okay, and as you see, the crystals are there in both cases, in the acute attack and in the intercritical period, which is asymptomatic period. So why in the asymptomatic period the patient doesn't have any symptoms, although the crystals are there? Okay, although the crystals are there, and why they have symptoms in the acute attack, while the crystals are still there. So what's the difference between these two? So actually the difference, what this illustration showing us, is that not the crystal per se that result in acute attack. They are present in both situations, in the asymptomatic period and during acute attack. They're always there. But what really causes the acute attack is the immune system when it gets activated for any reason, for stress, any stressful event that happens like illness, infection, is going to activate the immune system. And when the immune system gets activated, it will recognize the presence of the crystals. And because the crystals are considered foreign body, they're not supposed to be there, the immune system will start to attack them. So you see the immune system there, the round whitish things there, that are the neutrophils. No, I just want the pointer. I don't want this.
We have to install the software.
Okay, no problem. Okay, no problem. Okay, so you see here the white little round things, they are the neutrophils entering the joint. So this is when acute attack happens, because immune system now is attacking the crystals. So this will lead to the symptoms of acute gouty attack, the pain, swelling, and redness and heat. When the immune system is inactive and there is no interaction with the crystals, the patient doesn't have symptoms. So now this is the reason. Therefore, drugs used to treat acute attacks are those with anti-inflammatory or immunosuppressive properties, and they are able to calm down the immune system and stop it from attacking the crystals. Okay? So now we understand why we give these drugs for acute attack. As I said, effective treatment would be a drug with an anti-inflammatory or immunosuppressive property. The drugs used to treat acute attacks fall into 5 categories, so you can choose one of these 5 to treat acute attack. First of all, we can use steroids, we can use nonsteroidal, we can use colchicine, we can use interleukin-1 inhibitor, which is a biologic treatment, and we can use ACTH or synacthin. Now, regarding steroids, of course, steroids can be used oral, can be used IM, or they can use intra-articular. Intra-articular option is best for large joint with large effusions, where you can aspirate and inject. Oral option is best for smaller joints or for polyarticular gout, where you have several joints inflamed. And of course, you can give a course of cortisone like over 5 days, 40 or 30 milligrams or 5 days. And of course, you have the intramuscular option, but you should be careful and you should make sure that the patient doesn't have concomitant infection like a chest infection or UTI. Maybe you would rather choose, another option if there is infection. For nonsteroidal, so the common rule or the well-known rule for nonsteroidal is to use the minimum effective dose for the shortest period of time. Okay. because they're known to have, side effects if you use high doses for a long time. And of course, the non-steroidal, you would avoid them in patients with high GI bleeding risk and patients with high cardiovascular risk. So unless the patient doesn't have any cardiovascular risk and no GI bleeding risk, you have to always co-prescribe proton pump inhibitor with your non-steroidal. And of course, you should avoid giving combined non-steroidal and steroid together because it increases the risk of GI bleeding. Now, colchicine, there are 3 things you should know about colchicine. First of them, the timing. When is the best time to start colchicine? The dose and of course, the side effects. So the timing of colchicine, it's best time to give it where it's most effective, early during the course of an acute attack. And what do I mean by early? In the first 12 hours. And why is that? Because what actually colchicine does, as I showed you previously in the previous slide, that neutrophils, they will enter the joint to attack the crystals. So colchicine will prevent the neutrophils from entering the joint. It will prevent migration of crystals to inside the joint. It will stop this migration. So that's why it's very effective in the first 12 hours. After 12 hours, the joint will be loaded with neutrophils. There's no point of really giving the colchicine, or the colchicine will be less effective. And the second thing, the dose is 500 microgram BD, which is a low dose. You don't need to go anything higher than 500 microgram BD because as studies showed that higher dose is associated with more toxicity but similar efficacy. So really you don't need to go any higher than that dose. And of course, toxicity of colchicine, which mainly the neuromuscular toxicity. So when you use colchicine, you should avoid using it with patients with, low GFR or those with, impaired LFTs, or also you should look at the other drugs patient is taking to see if, may interact with colchicine and cause increased toxicity. Interleukin-1 inhibitor, so again, as I showed you here, interleukin-1 is the main messenger of the innate immune system, which is the key player in gouty attack, the innate immune system. So the resident immune cells that reside in the joint, when they're activated, they're going to recognize the presence of the crystal, and they're going to recruit neutrophils from the blood to enter the joint. So how do they recruit neutrophils? They recruit them through secreting a cytokine called interleukin-1. So there will be a surge of interleukin-1, and this will cause the neutrophils to enter the joint and cause the inflammation. So that's why we can use interleukin-1 inhibitor, but this is a restricted drug for rheumatologists. It's very expensive, and really it's not required in many cases because they can take the other cheaper options, and they're usually very effective. The last one is ACTH, or synacthin. This is a very good drug if you cannot use all the other ones because of contraindication to the others. It is safe in infection. It is it lacks the side effect of steroids like hyperkalemia, hypertension, and hyperglycemia. And as I said, it's safe in infection, and it's very potent anti-inflammatory. So you can choose any one of those to treat your acute attack, and the one that you can combine is usually the steroid and colchicine. They can be combined like for severe cases. So which one now to use for your patient? Now if you have someone with acute attack, which one to give? So this depends on the patient factors. So you need to look at the GFR. You need to look at the comorbidities, especially the peptic ulcer disease and cardiovascular disease. You need to see what medication he's taking, because if you want to give colchicine, you want to make sure that colchicine will not have interaction with one of the other medication leading to toxicity. And you want to know if the patient now is having a concomitant infection or not, right? Okay, the other things you can do is to rest and elevate the affected joint and use ice packs. And the most important thing, if the patient already established on urate-lowering therapy, please don't tell them stop urate-lowering therapy. This is a common mistake in general practice. We do not stop urate-lowering therapy during acute attack because there is no evidence that urate-lowering therapy can make the attack worse. So This was an old practice that is not really based on any evidence. Right. So, okay. This is, if you can. Sorry. I'm sorry, this interactive thing doesn't seem to be working here. Yes. Right. Okay, there's supposed to be a barcode where you scan and then you can vote for the correct answer. Anyway, we can just do it without the interactive bit. So in this case, for example, this is a young man with he doesn't have any non-medical problems. He doesn't take any medications, and he come with acute gouty attack. Now you assess him. He doesn't have any concomitant infection. He doesn't have any cardiovascular risk. He has low GI bleeding risk, and his GFR is normal. So which drug would you use to treat his acute attack? Actually, you can use any of them. He doesn't have contraindication to any of these medications, right? He can take steroid, he can take non-steroidal, he can take colchicine, but I would not choose colchicine if the attack had been there for more than 12 hours. You may give, but it will be less effective, so maybe I'll use something else. But this chap can take any of these medication, no problem. Now, this person, this 50-year-old male, he comes with a swollen knee. He has a normal GFR, no cardiovascular risk, and low GI bleeding risk, and he doesn't seem to have any risk of concomitant infection. So how would you treat his acute attack? So this chap, he can take colchicine, he can take non-steroidal, he can take steroid. There's no contraindication, right? But the best option for him, because the knee is a large joint and he has a significant effusion, very large effusion, the best option would be is for him to aspirate and the fluid and inject steroid. That's the best and quickest treatment for this person. Okay. Now the next case is this elderly gentleman who has peptic ulcer disease, ischemic heart disease, low GFR of 8. He takes aspirin, zocordilzium, and he doesn't have concurrent infection coming with acute gout attack. So which drug would be best to treat his acute attack? So of course you would avoid non-steroidal, right? Because he has peptic ulcer disease and he has ischemic heart disease and he has a low GFR. So non-steroidal is out of question. Colchicine, again, we're not going to give colchicine with a low GFR, okay? So this person can take steroids, but you should be careful because he's on aspirin as well and he has peptic ulcer disease. So probably you would like to give a PPI if you choose to give him steroids. And Synacthin also is a good option because it's safe. And it lacks the side effects of steroids and it's very potent. Right. Now this is an elderly lady who has H. pylori gastritis, a GFR of 48, and she's coming with acute gouty attack, and as well she has a UTI at the same time. So a UTI precipitated acute gouty attack. So which drug would you choose to treat her gouty attack? So anyone would like to give her steroids? Okay, you would probably consider other options because of the UTI. Anyone would want to give her non-steroidal? No, because she is old and she has H. pylori gastritis, and this is a very high risk for GI bleeding. Okay, anyone wants to give her colchicine? Yes, colchicine an option because her GFR is reasonable, is not very low. So a GFR above 30 is considered, safe for colchicine. And Synacthin, of course, is safe in all situations, so it can be given. So for this lady, colchicine, Synacthin, but Synacthin is usually non-IM, so she needs to go to the clinic to receive it. And she may need to repeat it the next day, so she may need to come again for another shot of Synacthin. Right, and okay, the last one now is an elderly man who's admitted to the hospital with septicemia, acute kidney injury, and upper GI bleeding. And he developed acute gouty attack while in the hospital. So who wants to give him steroids? No, because obviously he has sepsis, so no steroids. Anyone wants to give non-steroidal? No, because he has acute kidney injury and he has upper GI bleeding as well. Colchicine, again, is not an option because of the acute kidney injury. So we are left with one option, which is the Synacthin. Okay, so this is how you choose the drug to treat acute attack. It's very easy. Okay. Right, so now we finish with the acute attack. It's not very difficult. It's an easy, really easy step. Now we come to the real business. Now we come to the cure of gout. The second component of gout management, urate-lowering therapy. Now, treating acute attack will not solve the problem because as long as the crystals are there inside the joint, whenever the immune system gets activated, it will recognize the presence of the crystals, will attack the crystals, and this attack will result in acute gouty attack. And that's why the patient keep on having recurrent acute gouty attacks, because the crystals are still there. So actually the cure of gout is to get rid of these crystals. We need to dissolve these crystals. We need these crystals to disappear from the joint, okay? Now, to understand how urate-lowering therapy can cure gout, we need to understand the key pathologic process in gout. So first we need to know what is gout. Gout is deposition of monosodium urate crystals in joints and soft tissue around the joint, okay? So gout does not equal hyperuricemia. Okay, you need hyperuricemia, but not every hyperuricemic patient will go on to develop gout. They need to be genetically susceptible. Okay, only genetically susceptible patient will develop the gout with the hyperuricemia. Okay, so gout is the deposition of monosodium urate crystals in the joints. So actually what happens is that you have a saturation point above which, if you exceed the saturation point, then the crystals will start to form. And the saturation point is 360, the serum uric acid level in the blood, 360. If you exceed it and you're genetically susceptible, you're gonna precipitate crystals. Okay, so what happens if you exceed it? Crystals are gonna form and precipitate in the tissues. Okay, and crystal formation happens on a daily basis. So every day new crystals will form and deposit, leading to accumulation in the joint. Okay, so the key pathologic process in gout is a daily crystal formation and deposition in the joints. And this is what we call the crystal load. So the amount of crystal present in the joint is called the crystal load. And this crystal load, because the crystal formation doesn't stop, it happens every day. So with time, what happens to the load? It will increase, right? So this is just to illustrate to you what's happening with hyperuricemia and crystal deposition over time. So if you start with this patient, this is just an illustration. This is a knee. And when the uric acid level exceeds the threshold point, which is the red line here. So if you go above the threshold level, a high serum uric acid above 360, what's going to happen? The crystals are going to start to form and precipitate. So he will start to having crystals in his joint. And if you don't give him urate-lowering therapy to stop this process, what's going to happen over time? You have more crystals in the joint. You don't give urate-lowering therapy, you'll have more crystals, okay? And then you will have a massive crystal load over time, okay? And it's the higher the crystal load, the more difficulty to dissolve this load with urate-lowering therapy. So it's easier to dissolve it at an earlier stage than a later stage when the load is very high. Okay, so this is just to illustrate to you the course of the gout. So now we understand why urate-lowering therapy is important in curing the gout. Now we know we need to start it, but when should we start it? Do we give it after first attack? Do we give it as soon as we diagnose the patient? Should we wait for 2 attacks per year, or what do we, when do we give it? Right, now if you look at the available guidelines, if you look at the American guidelines, they give it late in the course of the disease. They want to give it if they have 2 attacks or more per year, or if they have renal stone, or they have tophi, or they have CKD, or they have radiological joint damage. And this is all late gout. Joint damage is late gout. CKD is late, okay? Tophi is late, so really you don't reach that late stage to start treatment, okay? And as Dr. Hiba said, in rheumatology, we want to treat early to prevent damage. This applies to gout as well. So the American guidelines, not really good. The British now, the British a little bit more, flexible. Yes, you give to patient with late gout, obviously you have to, but you can consider or discuss offering urate-lowering therapy to all patients who have a diagnosis of gout when they first present to you. So you can discuss it and decide jointly with the patient if they want to start or they want to delay. But the European guidelines, they say that urate-lowering therapy should be considered from the first presentation for the following reasons, because as I showed you, higher crystal load, that the longer you delay urate-lowering therapy, you will expose the patient to higher crystal load, difficulty in dissolution, and increased cardiovascular risk and renal disease. So the higher the crystal load, the higher the risk of cardiovascular and renal disease. And this recommendation is based on this following study. So as I told you, crystal load increases with time as new crystal they deposit on a daily basis. So the basis for recommendation of early initiation of urate-lowering therapy as soon as the patient presents to you the first time is based on the recent knowledge of the natural history of gout, expert opinion, and increasing imaging evidence that in gout there is damaging crystal deposition even at the time of first attack. Okay, so if you look at this graph here, the x-axis represents the crystal load. So this is the crystal here, the crystal load, and the y-axis present time. And you see with time what happened to the crystal load. It increases with time. Okay. So this graph shows us that gout evolved through different stages. Once it starts, it will not stop. It will progress all the way until the late chronic gout. So the first stage is the asymptomatic deposition here, so where the patient never experienced any joint pain, yet already accumulated crystals in their joint. As you see here, they have already some crystal load here, but they are asymptomatic, okay? Because crystal deposition is an asymptomatic process. They won't feel it, okay? So this is the asymptomatic crystal deposition period. The second stage now is when they start experiencing acute gouty attacks, okay, here. So these are the acute gouty attacks in orange. So by the time they present to you with their first attack, they already have a significant crystal load. And if you left untreated, the crystal load will keep on building up with time, and they'll experience recurrent acute gouty attacks, which will become more frequent, more severe, last longer, and you see the color and width of the acute attack increases with time, which means they become more severe and they stay for longer time. And you see the duration between the attacks becomes shorter, so they get more and more frequent attacks, right? So this is the natural history of gout. So if you leave this still, if you still don't treat it, they will eventually progress to the advanced gout, chronic gout, where there is persistent inflammation. So you see here, there is no asymptomatic period. The patient is always symptomatic. He's always having inflammation, almost looks like a rheumatoid arthritis. So inflammation is always there. This is called the chronic advanced gout, and we do not the patient to reach this stage because this is late. Okay, and we always want to treat the patient early to prevent complications. So that's why this is the basis for the earlier treatment of gout with urate-lowering therapy. So see the previous recommendation that you should wait for 2 or more attacks per year. This was supported by a short-term study in Canadian healthcare setting. They followed patients with gout after their first gouty attack for 1 year. So all those patients who got gouty attack, their first attack, they followed them for 1 year, and then they saw what's the percentage of those patients went on to develop a second attack in a year. So this study showed that around 60% of patients with gout had a second attack with 1 year. So you can see here, 60%, they will go into their second attack with 1 year. Then they said it's waste of money to treat everyone with first attack because 40% of those will never develop a second attack. But they missed this 40% because they only followed them for a year. The remaining 40% developed their second gouty attack, and you see in 2 years, 16%, 5 years, 11%, up to 13%, they all developed their second attack after 1 year. So they actually missed this because this was a short-term study. Right, so now you know about urate-lowering therapy, and we need to start it, and the reason why we need to start it. Now, when do you start it? If you decide to start it, during or after the acute attack? Do you wait for a patient to recover from the acute attack, or you give it during acute attack? Well, actually, there is no wrong answer for this question. You can either start it during or after, because the evidence behind this is very little. So again, if we take the British and European guidelines, they recommend starting urate-lowering therapy after acute attack, and the evidence behind this is just expert opinion and common sense. So they say is because you need to educate the patient, and when the patient is in pain, he will not absorb the information you're explaining to him. So better to postpone starting urate-lowering therapy until after the patient is free of pain, and then he can comprehend and understand what are you trying to educate him about. No any other reason for this recommendation. The American guidelines, they say you start during acute attack, and this is based on a small randomized controlled trial and some observational studies that showed that there was no worsening or lengthening of the acute attack episode. So really it doesn't matter if you start during or after, as long as you start the patient in urate-lowering therapy at some point. Okay, because this is what's going to cure the gout. Right, so how to initiate urate-lowering therapy? So this patient with the crystals in the joints, and you see his uric acid is above the saturation level, which is 360. Now, to make these crystals dissolve and to stop new crystals from being formed, we need to get the level below the saturation level. So we need to get it below 360, right? So for example, if you're going to start with allopurinol, you start with the lowest dose, which is 100, and you can use 50 in patient with slightly impaired renal function. So you start with 100, and then you check your urate, again, your uric acid level after 2 or 4 weeks. And if it's still above the target, 360, you increase the dose to 200. Check again after 2 or 4 weeks. If it's still you haven't reached your target, which is below 360, you increase it to 300. And in this case, we haven't reached our target, so I'll check again after 2 or 4 weeks. And when I checked, the level now went below 360. So this is the dose that the patient needs to take, 400 milligram of allopurinol. It's not 100, it's not 300. Okay, it's different according to the patient response. Each patient needs a different dose, so you need to escalate the dose and repeat the serum uric acid until you hit the target. Okay, so when we hit the target, we tell the patient, this is your dose, you will take it for life. Okay, it's 400 milligram of allopurinol. And then what's happened with time now, if the patient keep taking his compliant to his dose and his uric acid level is below the saturation level, so what's going to happen is that the new crystals will stop forming because there isn't enough uric acid to form the crystal, so there is no new crystal forming every day. And the pre-existing crystal, they cannot maintain themselves anymore because there isn't enough uric acid in the blood, so they will not be maintained. So what's going to happen over time? What's going to happen that the crystals will start to dissolve, okay? Until you reach a point where there are no more crystals, and this is when gout is cured, okay? But once gout is cured, how do you know? Of course, you're not gonna do some sort of imaging or aspirate. No, you only know by the patient haven't got any acute attack in a long time. Like you're following him up, like for a year, a 2 year, 3 year, he never got acute attack, so means he's cured, okay? So even after the cure, patient will need to take urate-lowering therapy for life. And this is simply because while gout is curable, and by that I mean by dissolving the crystals, you cure the gout because gout is deposition of crystals. On the other hand, you cannot cure hyperuricemia. This patient has a metabolic derangement in clearing uric acid. His body cannot deal with uric acid, right, because of the metabolic problem. So what happens if you stop urate-lowering therapy? Uric acid will shoot up again above the saturation level. And then what's going to happen? Then again, you have precipitation of crystals, so you will go that way again, right? So you'll go again. So that's why he needs to continue for life. But the only thing is that now he's cured, so he's not going to get any acute attacks, so he will never need the acute attack treatment again, right? And you need to explain to the patient that during this process, which might take years, it can take any time between 3 months to 3 years to get rid of the crystals and reach the stage. And this depends on how long the patient had gout for, how big is the crystal load. The bigger the crystal load, the longer duration you need to get rid of the crystals, right? So during this time, you need to explain to the patient that as long as there are still crystals there, okay, they are getting fewer, but they are still there. As long as they are there, they can be attacked by the immune system whenever your immune system is active. So you may get acute attack when you're on allopurinol. It doesn't mean the drug is not working, because what patients do when they take allopurinol and then they think that this is the cure, and then they get acute attack while they're taking allopurinol, what they're going to do? They're going to say it's rubbish, it's not working, and they're going to throw it, right? You need to explain to them, no, it is working, but it will take time. So if you get acute attack while on allopurinol, please do not stop it. It's working, but it will take time. And you will notice, although you're getting acute attacks still, because there's still crystal to be dissolved yet, these acute attacks will get less severe, shorter in duration, and they will be less frequent. Okay, so this is very important. That's why I'm saying patient education is the most important part of gout management, right? Now, what drugs we usually use for the gout? Of course, the first line is the xanthine oxidase inhibitors like allopurinol and febuxostat, and then you can use the uricosuric drugs. These are the second line, usually add-on. They're usually added to xanthine oxidase inhibitors if you cannot reach the target. But if xanthine oxidase inhibitors are contraindicated for some reason, they can be used alone. And there is also the uricase like bigloticase, but this is really needed because most patients, they do respond to the first line and second line, right? Now, when you initiate patient in urate-lowering therapy, you need to cover him in the initial period with acute attack prophylaxis. And that's because the dissolving crystals, they can activate a protein called inflammasome, which is present in the resident immune cells inside the joint. There is resident immune cells, and they have a protein called inflammasome. When the crystals start to dissolve, they're going to activate the inflammasome and the resident immune cells, and this inflammasome can trigger an acute attack. So while crystals are dissolving, an acute attack can be triggered in the beginning. That's why at the beginning of the treatment of urate-lowering therapy, we need to cover the patient for acute attack prophylaxis. You can give any of the drugs used for acute attack, like the colchicine steroid or even interleukin-1, and they are usually taken for 3 to 6 months when you start a urate-lowering therapy. After that, they can be taken only with acute attack SOS. But during the first 3 to 6 months, they need to be taken regularly. Right, now we come to the patient education, which is, this is really, really very important. So what you need to educate the patient about: self-treat acute attacks at home. You don't want to see the patient coming to you with acute attack. They can't treat them at home. They don't need to go to the hospital. It's very easy. Yes, you need to tell them that when they sense an acute attack is about to start, at the earliest sign of an acute attack, they should start acute attack treatment as soon as possible. So they should keep it at home with them when they feel that an acute attack is going to happen, and they know it because they experienced it before. They know that acute attack is developing. They should start their acute attack treatment as soon as possible to abort the attack. Okay, so if they do this, no one will come to you with acute attack. All acute attacks, most of them at home, will be aborted within, a couple of days. Because also, delaying the treatment, acute attack treatment, results in more severe and more prolonged attack that will be more difficult to treat. So if they start early at home, eventually they will not need to come to the hospital, but unfortunately nobody explains this to the patients, okay? So it's not the patient's fault, actually it's the doctor's fault, because they're not explaining this. The other thing is about so this is about self-treating acute attack at home. The urate-lowering therapy, what you need to tell the patient, first of all, urate-lowering therapy is not a painkiller. Many patients, they have a misconception that allopurinol is a painkiller, so only they take it SOS with the acute attack. So when I asked them, he said, yeah, when I have the pain, I take the allopurinol, and when it stops, when it's finished, they're gonna stop it. So they should know it's not a painkiller. It should be taken regularly. The other thing which I just explained earlier, that acute attacks can happen during urate-lowering therapy until all the crystals disappear. He can still have acute attack, but if it happens, it doesn't mean failure of the treatment, and they should not stop the treatment. Okay, and the last thing you need to tell them, do not stop urate-lowering therapy during acute attacks. Now, the other thing you need to educate them about is lifestyle. Well, the evidence for lifestyle is not really big. So that's why the mainstay of treatment of gout is with medication. Lifestyle have very small impact on the treatment, but mainly is the weight loss, and the evidence for weight loss positive impact in gout is from low quality evidence, or more moderate to low quality evidence. And they notice that there is an effect on reduction in serum uric acid with weight loss from low quality evidence, and there is reduction in gout flares, and achieving a target serum uric acid with weight loss also was observed, but a moderate quality evidence. But weight loss is a good thing anyway, so we should encourage the patient. The other thing is, avoiding certain types of food in gout, which you tell them, don't eat this, don't eat that, don't eat. Well, actually, this have very low impact on gout. So the study showed that there is very small effect on reduction in serum uric acid with avoidance of certain types of food, and reduction in gout flares. Really, there is limited evidence, and there is no data on avoiding food and achieving target serum urate level. That's why these things really they don't have a strong position in the recommendations for treatment. The diets that they are good for gout, there's the Mediterranean diet and the DASH diet, with the effect mainly on reduction in serum uric acid, but there is no data on reduction in gout flares or urate level, or reaching the serum target urate level. right? So I hope by the end of this talk that you learned the following points, which are very important, that gout is serious with severe long-term consequences. So as Dr. Hiba said, rheumatoid is serious with long-term morbidity if you don't treat it and you don't treat it early. Same thing with gout. Gout is not less serious than rheumatoid arthritis, so please take it seriously. And although gout is curable, patients are undertreated or not treated at all, and I mean by treated urate-lowering therapy. And when you treat gout, please consider the 4 aspects of gout management: treating acute attacks, urate-lowering therapy, and with urate-lowering therapy, you need to treat to target. You need to hit the target level of serum uric acid. If you don't do this, there is no point of urate-lowering therapy. If you don't reach a serum uric acid below 360, don't give urate-lowering therapy because it will not do anything. Okay? And the other thing, please educate the patient and screen a patient for associated comorbidities. Thank you.